Hello and welcome again to this GP Notebook podcast where we discuss bite-sized topics aimed at all those working in primary care. My name's Roger Henderson, I'm a GP in South West Scotland and I also co-host the GP Notebook study groups. Now you can find us on all major podcast platforms including Spotify, Apple and Google Podcasts, so do please follow us to receive notifications about new episodes, and if you're liking what you hear, do please consider leaving a review to help other listeners find us. You can also follow us on Twitter at GPnotebook or visit gpnotebook.com for podcast episode show notes and to find out more about our upcoming study group meetings. Now in this episode I'm going to be discussing carpal tunnel syndrome, which one of our listeners has asked us to cover, so many thanks for getting in touch with this great idea. Now, carpal tunnel syndrome, often called CTS, is the most common entrapment neuropathy we tend to see in practice, primarily affecting the median nerve at the level of the wrist. And the condition fundamentally results from compression of the median nerve within the carpal tunnel, leading to sensory and motor impairments in the affected hand. Now, the reported incidence of carpal tunnel in the UK population ranges from 88 or so to about 190 per 100,000 individuals, with a peak occurrence in the late 50s for women and the late 70s for men. Now, the gender ratio in younger people is around 3-1 in favour of females. I think it's probably worth a quick revisit of the forearm and wrist anatomy, first of all, though, which if you are anything like me as a medical student, it's never the most thrilling subject, particularly the structures associated with the median nerve, but I do think a very quick recap might be helpful in this case. So, the median nerve originates from the brachial plexus, receiving contributions from the C5 to T1 nerve roots, travelling down the arm, passing through the cubital fossa and between the flexor digitorum superficialis and profundus muscles before reaching the wrist. Now, the carpal tunnel itself is a narrow passageway located at the base of the palm and is formed by bones, the flexor retinaculum and contents. The floor and the lateral walls of the tunnel are composed of both the proximal and distal carpal bones. The flexor retinaculum is essentially the roof of the tunnel, a thick fibrous band attaching laterally to the scaphoid and trapezium and medially to the pisiform and hook of the hamate. Now, the carpal tunnel itself then contains the median nerve and 9 tendons, 4 flexor digitorum superficialis tendons, 4 flexor digitorum profundus tendons, and 1 flexor pollicis longus tendon. So you can easily see now why compression of the median nerve within this small confined space leads to carpal tunnel syndrome and causes both sensory and motor dysfunction. Now, if we look at some of the risk factors for developing carpal tunnel syndrome next, these include things like gender, inflammatory conditions, pregnancy, diabetes, and hypertension. So females have a smaller carpal tunnel cross-sectional area, and this increases their susceptibility to the problem. Conditions such as rheumatoid arthritis lead to synovial hyperplasia and compression. Pregnancy and the fluid retention linked to it increases pressure within the carpal tunnel. In people with diabetes, glycosylation and inflammation impair their tendon mobility and nerve function. And interestingly, hypertension appears to be initially protective, but later leads to microvascular compromise and chronic ischemic damage. Other risk factors to consider here include obesity, which is an increasingly common cause of carpal tunnel syndrome that I'm seeing, hypothyroidism, renal failure, and the menopause. Now, ultimately, though, I have found it to be quite rare to find any one single definite cause in a patient, and the overall view is that causation is very likely to be multifactorial. But the common endpoint for most of these potential risk factors is the development of raised pressure within the carpal tunnel and or the median nerve segment that lies within the tunnel. And this increased pressure can then trigger a chain of events that ultimately leads to ischemia and scarring of the nerve. And it's this ischemia that's usually the cause of the typical intermittent sensory symptoms that we see in carpal tunnel syndrome, such as numbness and pain. And if we look at the presentation of CTS, this is characterized by tingling, numbness, or pain in the distribution of the median nerve. So the thumb, index, middle fingers, and medial half of the ring finger on the palmar aspect. And this is often worse at night, typically causing the patient to wake, and they hang the affected hand out of their bed to try to ease their symptoms. It's often also worsened by prolonged wrist flexion activities, things like typing or driving or holding a phone. And over time, the pain may become more persistent and start to radiate to the forearm, elbow, arm, and sometimes I've even seen it to the shoulder. Now, weakness may be noted in both the hand grip and when opposing the thumb, and this is due to involvement of the abductor pollicis brevis and opponent's pollicis muscles. And you might also see some muscle wasting of the thenar eminence in more chronic cases. There are obviously differentials to consider here, although CTS is usually fairly straightforward to diagnose in my experience, but things like a cervical radiculopathy, say at C6 and 7, produces similar sensory deficits, but extends proximally along a dermatome. Thoracic outlet syndrome, for example, causes compression of the brachial plexus, but leads to upper limb deficits beyond the hand. Arthritis would present with joint pain and nodular growths, which typically would distinguish it from CTS. And any tendinitis tends to affect the muscles rather than the nerves and causes localized pain, but without any sensory deficits. Now, if we're looking at examining our patient with carpal tunnel, there are 3 basic physical examination tests I always tend to do in my surgery. And these are Phelan's, Durkin's, and Tindall's tests. So, Phelan's test involves putting the wrist into flexion for 30 to 60 seconds, and this reproduces the symptoms that the patient has been complaining of. Durkin's test involves putting direct pressure over the carpal tunnel itself to elicit the symptoms. And Tindall's sign is where we tap over the median nerve proximal to the flexor retinaculum, and this triggers tingling in the distribution of the median nerve. Now, we've been doing this for years and years, but there is a caveat here that I think has to be mentioned, which is that Tindall's sign has now been shown to be present in up to 40% of people without carpal tunnel syndrome. And the sensitivity of Phelan's test can range from as little as 10% up to as much as 90%. And so there is a view abroad now that says that these tests are not recommended to be as useful as they once may have been. However, I do think they are still worth doing in our surgeries. More complex investigations aren't usually necessary before starting simple treatment in cases that are clinically obvious. But if you have any diagnostic doubt, and certainly if you're considering surgery in patients, then nerve conduction studies should be done, because these measure conduction velocity across the carpal tunnel, and if you see slowed conduction, this indicates carpal tunnel syndrome. Now, electroneurography is probably the gold standard investigation here. And in this test, the median nerve is stimulated proximal to the carpal ligament, and compound muscle action potential is picked up over the thenar eminence. An alternative to this is EMG, or electromyography, which evaluates motor unit potentials of the abductor pollicis brevis and where increased spontaneous activity will indicate nerve damage. However, this is not as sensitive a test as electroneurography. If we're looking at imaging tests in patients with CTS, these include ultrasound, where increased cross-sectional areas of the median nerve and bowing of the flexor retinaculum are characteristic ultrasound findings. And MRI scanning can be used in complex cases to identify structural abnormalities, or if there have been ambiguous electrophysiological studies. Now, as a general point, if we're looking at treatment, patients with a clinical diagnosis of carpal tunnel syndrome who haven't had confirmation by investigations should be managed conservatively. If further treatment's required, then patients should be referred for electroneurography to classify the severity of their carpal tunnel syndrome and to guide our management. But it's really important to remember here that untreated carpal tunnel syndrome can spontaneously improve in up to 1/3 of patients, particularly in younger women, and I suspect that strongly represents a pregnancy subset here. So, if we're looking at conservative management first, this includes wrist splinting at night. And I say at night because wearing a wrist splint all day confers no extra benefit and is often restricting for the patient in their day-to-day activities. So in practice, there's almost no difference between splinting with the wrist in neutral and those splints with approximately 20 degrees of extension, except perhaps those in extension can be slightly more comfortable to wear. The splint should be worn for at least 1 month, and this is a very common treatment in our patients with carpal tunnel. But interestingly, a recent Cochrane review did find there was insufficient evidence to conclude whether splinting gave consistent benefit in people with carpal tunnel syndrome. So this might not be as clear-cut as we once thought. Non-steroidals obviously can provide symptomatic relief, and corticosteroid injections reduce inflammation via transcriptional suppression of inflammatory genes. Now, these are associated with an improvement of hand function at 6 months and a reduction in the need for surgery at 12 months. But obviously, the volume of any steroid used should be kept as low as possible because injecting fluid may worsen the already raised pressure in the carpal tunnel. You should really expect to see a response within 4 weeks at most. Stretching exercises can also improve the carpal tunnel space and nerve gliding, and ultrasound therapy using high-frequency waves can also provide anti-inflammatory effects and enhance nerve conduction. Now, if we're thinking about referral, I personally would refer patients if I'm uncertain about the diagnosis or when treatments have failed to work after 3 months. I also always refer patients with severe symptoms, especially if there's motor weakness of the thumb or persistent sensory or motor disturbances. Surgical intervention, and I'm thinking here of carpal tunnel release surgery, is indicated for severe cases with motor weakness, with muscle atrophy, or if conservative management has failed. And here the flexor retinaculum is divided to relieve compression on the median nerve, and this can be done now either by open surgery or endoscopically. Now, some of you might have patients who have had a relatively new, ultra-minimally invasive, sonographically guided and thread carpal tunnel release. And this option preserves the superficial anatomy, and minimises the potential damage linked to a surgical approach. Now, following surgery, any patient with simple desk-based duties can usually return to work after 3 days or so. If they have duties that require repetitive light lifting of less than 10 pounds in weight, this is typically about 10 days. But if they perform heavy manual duties, the usual recommended time to return to work is around 30 days. Now, after surgery, there is little evidence for any particular rehabilitation program being superior to another, and so this choice is usually based on what both the patient and clinician prefer. If we look at prognosis, finally, a poor prognosis is often associated with bilateral symptoms and a positive Phelan test, but up to 90% of mild to moderate carpal tunnel syndrome cases do respond well to conservative management measures, although some degree of recurrence is seen in 1 in 3 patients within 5 years of treatment, even after surgery. So, that's a quick overview of carpal tunnel syndrome, and I do hope you found the podcast helpful the next time you see a patient in your surgery with this particular problem. But have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you consider following the podcast and leaving us a review on your favourite podcast platform. It really does help. Do feel free to get in touch via social media at GPnotebook or email us support@gpnotebook.com if you have any questions, comments or ideas for future podcasts, as in this case. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, and also to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you so much for listening, and goodbye.